Hello, good afternoon, everyone. My name is Dr. Wisdom, and you are welcome to my YouTube channel. Today, I'm talking on vision loss of unexplainable cause, part 2. 2 weeks ago, I began with part 1 of vision loss of unexplainable cause. Today, I intend to take it a little bit further and then begin to teach more on it so that doctors all around the globe can gain insight and improve their practice wherever they find themselves. So quickly, I'm going to do a quick overview of what I taught last week, and then so that those who didn't join us or those who joined us will be reminded of what we discussed, and then we'll continue for today. So last week we began by saying that most vision loss that we call or we tag unexplainable are actually explainable. So the terminology unexplainable is not really unexplainable. So most times a patient comes and then tells you that the vision loss cannot be explained. There's usually an explanation for most and virtually all forms of visual loss. So it is expedient that a doctor is well grounded and he knows what he's doing, and then he's able to maneuver through the hills and valleys to be able to come up with something that is of clinical significance. And again, I began to say that the inability of the doctor to find this dilemma usually leaves him frustrated. It also leaves the patient frustrated. So it is best for the doctor's interest that he understands these basic terms and know how to rigmarole around them. Again, we also say that time is of essence, that most tests are time consuming, they're expensive and discomforting. Hence, the practitioner needs to know what to do and what not to do so as to be effective and efficient. And then we went further to talk about case history, and then I told you that case history is solves 80% of your challenges. Case history solves 80 to 70% of your challenges. So a good case history helps to unravel every dilemma found in a clinic. So it is important that everyone is grounded in good case history taking and then be able to use it to find out what actually is wrong. And I also began to say that case history talks about the components of a case history, talks about the duration, the onset, and last week I was not able to note that in terms of onset, that vascular oriented um, conditions usually last for seconds. Traumatic oriented conditions will last from seconds to hours. Inflammatory oriented usually lasts from minutes to days. And chronic stroke degenerative conditions will last from minutes to months and possibly years. And then elevated intracranial pressure lasts from minutes to also years. So this will help you to guide you when you are looking at onset under your case history. And we also say that predisposing factors should be noted during case history, associated signs and symptoms, severity, is it transient or sudden, is the vision loss transient or is it sudden. Also, we also say that the medical history of the patient is also important. The family history, the patient ocular history, the patient medical history, the patient's family ocular history, and the family medical history is also important. We also say that drug history is also important. It's good to know the drugs the patient are taking, whether topical or systemic. It has a way of guiding a practitioner to know what to do and what not to do. And then we also said that in last 2 weeks, that is part 1 of unexplainable vision loss. I began to say that categories of vision loss could be either optical related, it could be macular related, it could be neural, it could be chiasmal, it could be retrochiasmal, it could be visual pathway, it could be developing amblyopia, it could be malingering. The patient can also be malingering, and then you won't know. Maybe because his friends are wearing glasses, and then he feels he too needs to wear glasses. So he comes to the clinic and then begins to act all sort of drama. So it also can be a case. And then it could be psychological disorder. It can also be systemic disorders. For instance, a patient who has diabetes can come to the clinic and report of sudden vision loss, or a drop in a VA. So for such patients, once the diabetes is managed, vision is restored. Are we together? So systemic conditions can also lead to unexplainable vision loss. And then I also went further to say the last time that optical causes can be differentiated um, from other causes, and then the optical anomalies will appear as refractive errors, which is blurry vision at far or at near or both, diplopia, headaches, astigmatism, halos, difficulty concentrating after a while. It could also be macular diseases, and I also see that macular diseases will appear as metamorphosia, micropsia, loss of central vision, difficulty recognizing familiar faces, or the area of no vision. And also optic neuritis can also be a major cause of vision loss and appears as difference in color. For instance, you bring a, assuming this is a red bottle, for instance, and then you present it to one of the eyes, and the patient tells that this thing is appearing red, and when you are present it to the other eye, you say that it appears faded. It could also be a sign of optic neuropathy, the difference in color perception. But then this is the difference in color perception is a subjective test. A patient who is not observant might give you a wrong answer. So it's also a subjective test. So you must be careful by just following it hook, line, and sinker. And then I also say that we do pinhole to differentiate a refractive case from a non-refractive case. So when a case of vision loss is brought to the doctor or the practitioner, the next point is to do a pinhole. So any improvement in vision upon pinhole is signifying that this case is not totally a refractive case. But then a case of glaucoma, for instance, which is pathological, there might still be improvement in pinhole. So it shows that there is pathology there, and there is also a refractive error. So this is what we were able to talk about last week. Last 2 weeks. And then this week we want to take it a little bit further and then find common ground and make progress. And this week we are looking at so if the pinhole increases vision, like I said earlier, what are we looking out for? Assuming the patient comes in with 618, 612, for instance, and then upon pinhole you are getting 6966. Yes, it is indicative that this vision loss that is unexplainable can now be explained. It is a refractive condition. And then what are the likely pointers we are to note? The first pointer we are to note is it could probably be a case of wrong refraction. Maybe a refraction was done, and then that is why the vision loss was reduced. So an objective and subjective refraction should be done in this case and be reviewed. So, and sometimes it is best we do cycloplegic refraction, which will also be an added advantage. So cycloplegic refraction is the gold standard in children and adults with active accommodation. So in cases of children, adults with active accommodation, people in cases of pseudomyopia, latent hyperopia, accommodative insufficiency, accommodative spasm, and fatigues, it is wise we do cycloplegic refraction, because it paralyzes the ciliary muscle and then it reveals the whole state of the eyes. So most times when you don't do your cycloplegic refraction, you might not uncover underlying refractive error. So it is good that cycloplegic refraction is adopted in every and all clinics. It helps to explain why the refraction went wrong. Are we together? And also, I want you to note that cycloplegics are contraindicated in patients with shallow anterior chamber. So when you do your maybe your gonoscopy or with your slit lamp or with your pen touch, and then you find out that the anterior chamber is shallow, it is not wise to do cycloplegic refraction, because it can even close up the little anterior chamber that the patient have. And if the anterior chamber is closed or blocked, aqueous humor will not be able to flow. Remember, the aqueous humor is produced from the pars plicata and then flows posteriorly to anterior. So it baits the lens for the pupil, it enters and then goes through the anterior to the anterior chamber and then to the trabecular meshwork and flows out. So if the anterior chamber is narrow and then if you dilate it, the junction, the iridocorneal junction will become little and then the anterior chamber will become little in size, which means aqueous cannot flow out well and then it can lead to a build-up in intraocular pressure. And we don't want intraocular pressure to build up because the normal range of intraocular pressure is 10 to 21 millimeter mercury, and we don't want anything above 21 millimeter mercury. So cycloplegic is contraindicated in people with shallow anterior chamber, and also people with angle closure glaucoma, people who are susceptible to angle closure glaucoma. It is not wise doing a cycloplegic refraction for them. Also, people with history of allergy or sensitivity to cycloplegic drugs. A patient has told you before that, oh, the last time I did this, look at the condition, this is what happened. It is not wise to do a cycloplegic refraction for them. So this is the first point. So the second point that can go wrong, or why pinhole improved the vision that was once unexplainable, could be due to corneal pathologies. So corneal pathologies can also affect the vision of the patient. So disease is affecting the corneal epithelium. Remember, the cornea has various layers. We have the anterior layer, we have the Bowman's, the corneal stroma, the descendant membrane, and then the endothelium. And then there is also a hypothetical membrane called the Duas layer, which is still under subjection. Some people are saying it's there, some are not saying it's there, but it's not our emphasis for today if it is there or not. So we'll leave that for the researchers to fine-tune that. But then if anything affecting the corneal epithelium can lead to a reduced vision acuity, e.g., a defect in tears production can lead to a loss in vision. Remember, the tears has 3 layers: the lipid, the aqueous, and then the other layer, the 3 of them. So if something affects the lipid layer, it then means that the tears will evaporate fast, and then it can lead to vision loss. So anything affecting the production of tears can also cause vision loss. Also, chalazion can also cause corneal astigmatism. So chalazion can induce corneal astigmatism, leading to a loss in vision. So once the chalazion is treated, and then chalazion also can appear as style, but the differential diagnosis is that chalazion is painful, while chalazion is not painful, it's painless, while style is painful. So this is one of the differential diagnosis of chalazion. Chalazion is painless, while style is painful. So what I'm saying is that chalazion can also induce corneal astigmatism, leading to a loss in vision. Also, early keratoconus can also lead to loss in vision. Remember, keratoconus is the bulging and thinning of the cornea. So it can also lead, and most times early keratoconus might not be detected. So that is why it's good keratometry is done to determine if there is early signs of keratoconus. So this is one of the reasons, or these are one of the reasons that unexplainable vision loss can be seen in a clinic. And then when optical defects have been ruled out, what do we do next? We now do what we call the swinging flashlight test. The swinging flashlight test should be done when you have ruled out a wrong refraction, subjective and objective. That is subjective, I mean with your subjective examination, and objective either with the retinoscope or the autoref, and you've ruled out a wrong refraction. You have done your cycloplegic, you have looked at the cornea on the slit lamp. There are no corneal pathologies. You have ruled that out. There are no stars, no chalazion, no keratoconus. You have ruled that out. So, and then you want to probe further. The next test we can do is the swinging flashlight test. Like it's called, the swinging flashlight test is a test you do by swinging a pen torch over the pupil to determine if there is any afferent defect. So the swinging flashlight test can detect relative afferent pupillary defect. It is afferent because it is from an organ to the brain. It is from a site to the brain. But if it is from the brain to an organ, or from the brain to the site, it is efferent. So afferent is going, while efferent is coming from the brain. So a relative afferent pupillary defect can be detected during the swinging flashlight test, and if present, can one of the cause of unexplainable vision loss. So RAPD is relative because we are comparing one eye to the other. This is why it's called relative. It is relative because we are comparing the right eye to the left eye, or the left eye to the right eye. And again, afferent, like I said earlier, is a neural impulse carrying signals from a sensory receptor or organ to the brain or spinal cord for further processing. So when we are carrying information to the brain or spinal cord for processing, it is called an afferent pathway. And then when anisocoria is present, or one or both pupils does not react to light, the swinging flashlight test is not reliable. Anisocoria, a difference in pupil size, is present, or one of the eyes does not react to light, swinging flashlight test is not reliable. Remember, it is relative because you are comparing an eye to the other eye. And then you should note that the swinging flashlight test is done in a dark room, and the patient should be fixating at 6 meters. So the patient should be fixating at 6 meters. The distance is 6 meters. The illumination is in a dim room, and then it is done on one eye and then on the other eye. So the position of the patient is also important during swinging flashlight test, and also the position of the examiner. And so there are also drugs that can induce that can cause the pupil to lose its size. So you must note, you want to know why are the pupils not of the same size. Could it be that the patient is on a drug, and could it be that the patient, for instance, if the patient is dilated, the pupil size will be larger than normal. And then if it's a dilatation, so there's a difference between dilation and dilatation. In dilation is when it is induced by the doctor. When the doctor induces the pupil size to be dilated, it is called dilation. But when it is not induced by the doctor, it is due to a pathology or something else, it is called dilatation. Are we together? So there's a difference between dilation and dilatation. And then I also want you to note that a normal swinging flashlight test is when both eyes constrict when light is shined on one eye, and a weak pupillary constriction in the affected eye accompanied with dilation of both eyes indicates RAPD of the eye that the light was shone on. So a weak pupillary constriction in the affected eye accompanied with dilation of both eyes indicates the presence of RAPD, and then this should be probed further. So while doing this test, certain you can see certain errors, or certain errors might be noted while doing your RAPD, and I want you to note these errors so that you will not get a wrong result. One of the errors you can notice during the swinging flashlight test is a too bright or too dim stimulus. If the stimulus is too bright or too dim, you are likely to get an error. Also, a difference in time spent observing one eye compared to the other. So if you assuming you spend 5 seconds in the right eye and then you spend 3 seconds in the left eye, you might not get accurate results. So it should be, if you are using 2 seconds for the right eye, it should also be 2 seconds for the left eye. Also, accommodating during the test. So the patient is supposed to be looking at 6 meters, but then when the patient begins to look at 40 cm, he's accommodating. And remember that during accommodation, the pupil also constricts. The pupil constricts during accommodation, so you can get a wrong result if the patient accommodates during the swinging flashlight test. So it is expected that the patient looks at 6 meters and maintain that fixation while doing the test. Also, a change in fixation from distance to near can also stimulate accumulation. I've said that. And then difference in the distance and angle of illumination. So if the angle of illumination is different, you can also notice error during the test. So this is that for the swinging flashlight test. Today's class is going to be a brief class so that we can be able to understand all what I've said. And then part 3 will be the final class, or part 4 will be the final class. And then if both optic nerves are damaged to the same extent, RAPD won't be noticed, not minding the extent of the damage. So if both optic nerves are damaged to the same extent, you are likely not to notice RAPD because both of the optic nerves are sending similar information to the brain, not minding the extent of the damage of the optic nerve. So this should be noted. And then when RAPD is detected, perimeter should and must be done. Perimeter must and should be done because perimetry cannot be overemphasized in the profession. In fact, every clinic should have one, and every good doctor should know how to do one and interpret the results. So you in glaucoma, you do perimetry. In pupil anomaly, you want to know what is going on, you do perimetry. So it is very, very important that every clinic has one. And then perimetry is the primary testing modality for the detection of chiasmal and retrochiasmal disorders. So when we have visual pathway disorders and you want to know the extent of damage, perimetry is the choice instrument. It shows us that you can be seeing hemianopsia, you can be seeing a whole lot of things. So in perimetry, you can see this stuff. So this is that for the RAPD. So I'm not trying to explain the RAPD. I assume you know it already. I just want to relate it as regarding to vision loss of unexplainable cause. And then finally, macular disorders too can lead to vision loss. Remember, the macula is responsible for central vision, and sometimes most macula, or not most anyway, some macular disorders can go unnoticed. It can go unnoticed during fundoscopy, or even during your fundoscopy, or during your fundus camera examination. So, for instance, in a case of macular edema, you can, it depends on the severity anyway, it can be easily missed during fundoscopy. It can be easily missed. So this is why OCT is the gold standard in noting macular disorders and retinal disorder, because it picks up even minute little details. It picks it up. So when you've screened out optical causes, you know it's not a refraction case. You have done your RAPD and it seems as though everything is okay. You have done your perimetry, the results are okay. It is also wise you do send for an OCT. An OCT can detect a whole lot of things. I've done a video on OCT interpretation in the OSAF platform, the video will be out soon, and then you can glean from it. I also have materials on OCT. You can request for it. I'll send it to you on OCT interpretation. So when you have done this, OCT should be sent for. It can help let you know, oh, this thing we are seeing can be a retinal case. It can be a macular issue. So macular examination is very, very important. It's very, 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 very important in your in diagnosing vision loss of unexplainable cause. And then, like we said earlier, it can also be due to patient can be malingering. So malingering patient, most times when you put a plano lens, they tell you the vision is better, and you know the patient is malingering. So that is, you see that mostly in children. So malingering should also be ruled out. Also, psychological disorders. There are certain psychological disorders that can lead to vision loss. So issues affecting the brain, whereby the patient can no longer recognize letters they used to recognize before. This should be ruled out. So any issue affecting the visual cortex, parts of the brain responsible for identification of objects, can also lead to vision loss. So this should be ruled out and ensure that it is not what is causing it. And also psychological disorders. A patient who is not psychologically sound can also report of vision loss that is unexplainable. So you want to rule out that this case is not a psychological case, and if it is one, it is expected you refer to the appropriate authorities. And then, like I said earlier, systemic diseases, there are ocular manifestation of systemic diseases. You can know them by just mere inspection. So issues affecting the kidney can manifest in the eyes. For instance, jaundice can appear as yellow eyes. Diabetes can also can be seen in the eyes during ophthalmoscopy. Cholesterol buildup can appear as acus senilis or acus juvenalis. So a whole lot of them, even an increase in the blood pressure can be seen at the back of the eyes. You see the salute sign, the bonnet sign, the gun sign, the AV pain, the microaneurysms, cottonwool spots, all those stuffs. They can give you an insight in that this can be a systemic case leading to vision loss. So I think this is a summary of what I mean by unexplainable vision loss. So a quick recap, like I said earlier, every time a patient tells you that vision loss is unexplainable, most time it is explainable. It just behoves on the doctor to find out what actually is wrong and then do the necessary test in order to find out what is going wrong. So this is a summary, and this is the final class for vision loss of unexplainable cause. I hope to see you next week Sunday, same time, for another interesting topic. And make sure you like, make sure you comment, make sure you subscribe, and make sure you share this video. This is my own little quota of giving back to the society, because the society has invested so much in you and I. So every time I have the opportunity to give back, I don't hold it back. So I'm going to see you next Sunday, same time, same venue. We are going to be looking at an interesting topic, and then we are going to be looking at it together and trusting that we make progress. I am Dr. Wisdom. Have a good day and remain blessed.